We're going to take the rest of the session to field some questions from the audience, but to begin with, I'll have our ARS question from the initial opening of the session brought up to see if any of the responses have changed. In my practice, I assess for the possible contribution of IOP-independent factors such as vasospasm, migraine, hypotension, as was discussed, in which of the following patients: patients with or suspicious for normal pressure glaucoma, patients with glaucoma who progress despite office IOPs at goal, both 1 and 2, all of my patients with glaucoma, or none of my patients with glaucoma. And the comparison of pre and post looks like there's a few more at number 3, but pretty similar between beginning and ending of the session. Thank you for your participation. So to begin the question and answer session, one question we've seen a couple times here, Dr. Ross may be the one to first address it, but to all of the panel, they can chime in. If we're considering normal pressure glaucoma diagnosis of exclusion, would you recommend neuroimaging in all patients across the board?
No, and that's part of the reason I did the middle audience response questions is that particular diagnosis would have been missed if you had just gotten an MRI with contrast. You would have missed the optic nerve sheath meningioma because of the visual field, because of the clinical exam, because of there are a lot of other hints in the patient when the patient presented. That's when I knew to order the orbital imaging, which may not be the go-to imaging for other patients that are presenting with normal tension glaucoma. I think it's a careful history. I think it's a careful exam. It seems very rudimentary, but it's true. Just taking the time, stopping, thinking about how the patient is presenting and trying to localize the pathology is what I would recommend. Because if you get an MRI and you see something, you don't know if it's contributing or not to the disease. So there has to be a little bit more evidence and diagnostic indicators for that, for me.
So we'll go on with another question that was asked more than once. We'll start with Dr. Piltz, but again, anybody else feel free to chime in. When it comes to the use of topical beta blockers in normal pressure glaucoma patients, don't use at all, use later in the therapeutic steps, use Q-day versus BID.
So if you have alternatives to beta blockers, use your alternatives first. If we still want to get the pressure down, so if that's your only alternative left, you can try betaxolol first. You could also just try Q-day and in the morning. So we don't want to dose beta blockers at bedtime because I mentioned before they don't work when we're sleeping and they can lower the systemic blood pressure. So it's not an absolute, but if you have alternatives, go with that first.
All right, and another question for Dr. Desmarais. In terms of the disc hemorrhages, if that's seen on your exam, do you tend to have a standard approach? For example, do you advance treatment for all patients with a hemorrhage, or is it more of a situational basis?
I tend to escalate therapy whenever I see a disc hemorrhage, yes. Something I wasn't able to make the point very clearly is that IOP reduction slows the rate of progression after disc hemorrhage, but it has to be very substantial. And even those studies, if you look at the rate of progression after escalation of treatment, it is still much faster than what's usually seen at that level of visual field loss. So it seems like even having this approach, you're still probably not going to slow that much to prevent vision loss.
I agree with Gus. If I add some comment, if the disc hemorrhage is related with notching or no fiber layer damage, it's very important, it's very risky, and also the hemorrhage is recurrent compared to before, so it will be more significant.
Question for Dr. Gherkin or anybody else. If you feel that there is concern of sleep apnea, are you ordering this test yourself or asking the internist to order it? And then the question is, how do you interpret it, as so many patients seem to show some evidence of sleep apnea at times, particularly if they're sleeping on their backs?
Yeah, I think we're not really equipped to do or interpret the test. So the formal testing for sleep apnea really should be done through the patient's primary care doctor. There are a number of, and because of the high prevalence both in cases and controls of sleep apnea and that increasingly high prevalence, I think there are a number of sort of healthy lifestyle options that we can provide our patients that we can intervene with. So the standard smoking cessation, which we're pushing anyway, weight loss, avoidance of alcohol in the evenings, those sorts of things are advisable across the spectrum, whether they're a case or a control. The other issue, sleep apnea is certainly important, but it's not if you look at the broad epidemiologic literature, it's still kind of a minor league risk factor, and that doesn't have the impact of IOP or corneal thickness or these other larger and more impactful risk factors. But targeted in a population that's progressing with those symptoms, it may be important to be more aggressive. There still is no prospective studies that treatment of sleep apnea slow progression, and that's really an important piece of the puzzle.
Thank you. Oh, say.
I'll just add to that apparently CPAP causes elevation of intraocular pressure.
So one question I would address to the whole panel, and maybe we can start with Dr. Piltz and work our way down. In light of the LIGHT study recently being published, there is somewhat of a renewed discussion about the role of selective laser trabeculoplasty earlier in the treatment paradigm, and obviously those patients were not a normal pressure glaucoma population, and we know that we traditionally see better efficacy with higher baseline IOP. Do you feel SLT has any role in normal tension glaucoma, and do you consider it as an option?
I still would consider SLT for normal pressure glaucoma. Yes, you get less bang for the buck, but it's pretty low-hanging fruit in terms of it being very safe and tolerated, and has a potential in some people to work nicely. So since it has a low-risk profile, I think it should still be considered and take the successes when you get them.
Yeah, I agree and mirror everything Dr. Piltz said. And then the other part is the intraocular pressure control that we're not measuring, which is at night. And I think that SLT, in addition to lowering the pressure for what we see in the clinic, provides a more stable intraocular pressure throughout the day. So that's why I often offer it, also because it is low-hanging fruit as well.
I'd like to echo that even though the mean IOP lowering is minimum in low teens or mid-teens, but the fluctuation itself may be benefit. The fluctuation may be decreased after SLT.
Yeah, I would agree with that. I think with the triggerfish device, they've shown where IOP fluctuations before and after SLT, even though mean IOP did not change, there was a significant reduction in fluctuations. And we know from some of the bigger trials that in those low pressure patients, it's more the fluctuations that could be damaging than the overall mean IOP. The other thing is we may be missing higher pressures outside the clinic. I continue to be amazed with home IOP monitoring and the amount of spikes that we're catching with people who seem to be controlled in the office, that we're actually just missing those spikes.
Yeah, there's always that caveat of well-controlled office pressures. So along the lines of issues related to sleep, and I will just mention as an aside that probably one of the simplest ways that's been suggested to prevent sleep apnea, since it occurs for most people when they sleep on their back, is just to prevent people from sleeping on their backs, which can be done by even buying a shirt that has a little balloon in it that you inflate so that you don't sleep on your back, because if you roll over on your back, it's uncomfortable. Or it's even been suggested to me by an internist that just have them sew a tennis ball into the back of their nightshirt. That'll keep them from doing that. But along those lines, Dr. Piltz, I mean, should we be making recommendations to patients of sleeping with their heads propped up, or Should we, Dr. Park, be asking patients to not sleep on the side with worse disease? Should they be wearing an eye shield on that side? Do we do these things?
So I actually have recommended eye shields in certain patients, the patients that really jam their eyes into the pillows. I never know what to say about sleeping on pillows because when you raise, so you'll have less intraocular pressure elevation, but you'll also have less rise in perfusion pressure because your eye is elevated above your heart. So I don't know the answer to head elevation, but yeah, anything that will, I do have recommended either LASIK shields or shields sometimes when people have had progression, especially if they say, I always sleep on my right side, and that's the eye that they have worse glaucoma. You just try to cover all bases if you can.
Dr. Park?
Yeah, it's very difficult to say to the patient not to sleep on the side because if the patient getting older, the time of side sleep is longer and longer. So what I recommend to my patient is that do not sleep in prone position. You can sleep side, but prone position, if you sleep at prone position, your head is like this and your eye is on the pillow. So the worst eye should not be in that position.
But I do like that tennis ball thing.
Yes.
It's very cheap.
Well, that's the end of time for our session, so I want to thank the panelists again for an outstanding session and the audience for their participation. We'll begin the next session shortly focused on glaucoma and anterior segment disease.